So, the learning objectives that we're going to cover in this talk are going over the anatomy and physiology of the stomach and gastric acid secretion, understanding the pathophysiology behind peptic ulceration in the stomach and duodenum, and then also knowing how to diagnose and treat peptic ulcer disease. And then, depending on how much time we have, we'll briefly touch on which patient populations may need prophylaxis for prevention of ulcer disease. So, peptic ulcer disease has a lifetime prevalence in the general population of about 5 to 10%, with an incidence of 0.1 to 0.3% per year. The rate of hospitalization, admissions, and mortality luckily have been sharply declining over the last 20 to 30 years. And part of that is because the incidence and prevalence of peptic ulcer disease is directly related to H. pylori infection rates. The incidence increases with age for both types of ulcers, and in duodenal ulcers, you can see those typically 2 decades earlier than gastric ulcers, especially in males. In the US, about 4 million people have active peptic ulcers, and about 350,000 patients are diagnosed every year. And of these cases, 4 times as many are duodenal ulcers as gastric ulcers that are diagnosed. And as far as the death rate, approximately 6,000 patients die every year from ulcer-related complications, and that's about evenly split between the two types of ulcers. So the thing about the signs and symptoms of peptic ulcer disease that kind of makes it difficult is it's a lot of the symptoms are non-specific, so there's a limited predictive value. But some of the things to think about when you see these patients, whether it be in the clinic or in the hospital, with regards to the two different types of ulcers are for gastric ulcers. Think about that if you have a patient with postprandial abdominal pain, nausea, vomiting, or weight loss. And then for duodenal ulcers, these patients may report hunger or nocturnal abdominal pain. Also, depending on what their causative risk factor is, whether, for instance, an H. pylori or an NSAID-induced peptic ulcer disease, they may have a relapsing and remitting course or pattern to their symptoms. And some of these patients, especially the elderly specifically, are frequently asymptomatic, so that can make it even more difficult because they won't really give you anything in the history to go off of. And then the main complications of peptic ulcer disease include bleeding, perforation, and gastric outlet obstruction. So I'm sure by this point, a lot of you have probably seen the patients that come in with GI bleeds, upper GI bleeds, whether that be melena or hematemesis, and that's secondary to peptic ulcer disease. And these symptoms can happen with or without warning. And I think a lot of times what we see in the hospital is the patients that come into the ED because they just develop melena, either that morning or like the day before, and they have a hemoglobin drop and, end up having a bleeding ulcer. And though hospital admissions have decreased, the case fatality rate remains at 5 to 10%. And if they have a perforation, the mortality rate of that complication can be as high as 20%, depending on their age and comorbidities. And endoscopy is the gold standard for diagnosis. And it's really important to remember that when you have these patients, you should test them for H. pylori, because as we'll talk about later, testing and treating and eradication of disease can play a really significant role in decreasing the risk factors associated with ulcer disease. So moving on to a little bit about the anatomy and physiology of the stomach. So there's 3 main regions in the stomach: the fundus, the body, and the antrum. The fundus and the body are comprised, or they have more parietal cells. And are you able to see like me pointing here with my cursor? And then,
Usually we can, but I don't see it.
okay, sorry. So kind of towards the bottom of the stomach is where the antrum is by the pylorus, and that's where the G cells are. And so the glandular mucosa is organized into vertical tubular units. The mucus producing pit cells migrate upwards from the progenitor cell towards the gastric lumen, and acid secreting parietal cells migrate downwards towards the middle and the lower regions of the gland. So you can see the pink blocks in the left-hand figure. These are the parietal cells that release the gastric acid. The chief cells are found mostly at the base, and those secrete pepsinogen, and the chief cells are the blue blocks. And then you have a variety of distinct neuroendocrine cell types that are contained within the gland, but only some of their products have been assigned physiologic functions, such as the enterochromaffin-like cells or the ECL cells, and those contain histamine. And then the G cells, which we spoke about on the last slide, are here at the bottom in the yellow blocks, and those secrete gastrin, which then stimulates acid secretion. So a little bit more on acid secretion. The parietal cells secrete hydrochloric acid at a concentration of approximately 160 millimoles, or a pH of 0.8. The acid is produced from the hydration of CO2 to form hydrogen and bicarb ions, and then this reaction is catalyzed by carbonic anhydrase. And at rest, the tubulobesicles are the site for storage of the majority of a membrane-bound transporter. This is the ATPase or proton pump, which is then sequestered from the lumen. And after activation, these membranes are brought into continuity with the apical membrane, and so the density of proton pumps in the pole increases. And these pumps are the site of active pumping of protons into the gastric lumen. So this slide shows in the bottom, or like on the right-hand side of the slide, you can kind of see over here all of the different defenses that we have against peptic acid. And H. pylori and NSAIDs specifically attack the first line of defense, the mucus, versus acid, which affects the bicarbonate barrier. And then what happens is that this results in altered barrier function of the apical plasma membrane and the intrinsic cell defense, which then causes blood flow mediated removal of the back diffuse hydrogen ions and ultimately results in epithelial cell injury. So moving on, we'll talk a little bit about the pathophysiology of how peptic ulceration occurs in the stomach and the duodenum. So as you can see, and as y'all are probably aware, there's a very fine balance between the protective factors and the hostile factors. And when the balance or when the scale is tipped in the wrong direction is when we end up with an ulcer. And so what happens is the way this occurs is that there's inhibition of endogenous prostaglandin synthesis, which leads to a decrease in epithelial mucus, the bicarb secretion, mucosal blood flow, epithelial proliferation, and ultimately causes decreased mucosal resistance to injury. And then this lowered mucosal resistance then results in injury or leaves the cell open to injury from endogenous and exogenous sources. And nitric oxide is recognized as a critical mediator of gastrointestinal mucosal defense by increasing the mucosal blood flow, and it prevents neutrophil adherence to the vascular endothelium. The products of the enzymes nitric oxide synthase and cyclooxygenase tip the balance between gastric epithelial apoptosis, which is how we get ulcers forming, and cell proliferation and healing. And so down here, you can see the microscopic view on the left of an ulcer forming from the offending agents causing damage. And then on the right is the endoscopic view. And so similarly, in NSAID-induced mucosal injury, what we talked about is what happens. The irritant effect of the NSAIDs works on the epithelium. It changes and impairs the barrier properties of the mucosa, decreases the blood flow, and interferes with the ability of the cell to repair superficial injuries, leading to deeper mucosal injury. And NSAID's systemic ability to suppress gastric prostaglandin synthesis occurs by inhibiting the COX pathway via arachidonic acid to prostaglandins. This mechanism is independent of the way H. pylori causes damage to the cell, and we'll talk about that in a minute. And also, one thing to note is that NSAIDs are more likely to cause gastric over duodenal ulcers. So this table, I think, is good because it shows some of the different types of NSAIDs, and a lot of them I think are ones that we often prescribe, or at least both in the outpatient and sometimes in the inpatient setting for pain or other indications. So table 2 shows the different odds ratios and the risk of bleeding associated with the different types of NSAIDs. So that's something to just keep in mind, when you're thinking about giving any of these medications to a patient. And then table 3 goes over the risk factors that for NSAID drug-induced ulcer complications. So some of the definitive risk factors include things like if you've had prior peptic ulcer disease, if a patient has had complications, GI complications in the past, or if they're on other drugs at the same time, such as steroids or anticoagulation that increase their risk of bleeding, if they're advanced age or have multiple comorbidities, or even kind of a dose-dependent thing with if they're on multiple NSAIDs or if they're on higher doses of the NSAIDs. And then for possible risk factors, things to keep in mind are if they're smokers or heavy alcohol users, or if they have H. pylori infection as well. And then moving on to H. pylori-induced mucosal injury. So, we talked about NSAIDs and then H. pylori. These comprise the 2 most common causes of peptic ulcer disease. And the H. pylori is the prevalence is inversely related to socioeconomic status. In these patients with duodenal ulceration, the infection with H. pylori is associated with increased basal and stimulated plasma gastrin concentrations and acid outputs. And H. pylori causes a massive inflammatory response that then results in gastric epithelial cells secreting a lot of chemoattractants for the neutrophils and IL-8, which then causes a massive neutrophil infiltration. And lipopolysaccharides, ureases, and vacuolating cytotoxins are amongst the factors that also allow H. pylori to persist in the gastric mucus and invoke the inflammatory response, which ultimately causes damaged host cells and a peptic ulcer. And then one thing to keep in mind is that the genes in the CAG pathogenicity island also contribute to inflammatory response because they initiate a signal transduction cascade, which results in increased IL-8 production. Pro-inflammatory cytokines and a Th1 cytokine response also further exacerbate all this inflammation. And the other thing I wanted to point out on this flowchart is that depending in states of chronic H. pylori infection, they can affect different parts of the stomach. So one thing to keep in mind is that depending on where the gastritis has a different effect on the balance between gastrin and somatostatin. So in antral predominant gastritis, you have probably high acid output states, and that is, you'll see that with duodenal ulcers, versus like in corpus predominant gastritis, you want to think more about low acid, and those patients you may see gastric ulcers, intestinal metaplasia, or gastric cancer risk. And then just some other things to briefly touch on as far as other causes that are less common, but also important to consider in the differential diagnosis when we see patients that we think may have peptic ulceration. So gastrinomas or, Zollinger-Ellison syndrome, think about this especially in patients when you see peptic ulcers that are in unusual locations like the jejunum, if there are states of massive gastric acid hypersecretion, and, obviously if they have a gastrinoma. And then when healthy volunteers received IV infusions of calcium, they found that it induced gastric acid hypersecretion. So calcium has been shown in vivo and in vitro to stimulate gastrin release directly from gastrinomas. So resolving the hypercalcemia, for instance, by a parathyroidectomy, can reduce the basal acid output and the serum gastrin concentration in fasting gastrinoma patients and those with MEN1. So that's just something to keep in mind. And then smoking is another risk factor. The people that smoke are about 2 times as likely to develop ulcer disease than those who do not smoke. And there's also a strong association between H. pylori infection and cigarette smoking in patients with and without peptic ulcers. And the reason that this is thought to be is because smoking is thought to increase the susceptibility, diminish the gastric mucosal defensive factors, and also it just overall may provide a more favorable atmosphere for the H. pylori infection to thrive. And then the last thing to mention is stress and alcohol. As risk factors, chronic active gastritis is reportedly associated with chronic alcohol ingestion, and the inflammatory changes that are seen in alcoholics are likely to be related to concurrent H. pylori infection that is common amongst alcoholics. So moving on to the next learning objective, we're going to talk now more about diagnosis and management and some of the treatment options of peptic ulcer disease. So this is kind of a busy slide. It's got a big algorithm on it, and we'll kind of walk through the flow chart together. But the take-home point of this is that the overarching thing to remember is prevention is key. Evidence suggests that eradication of H. pylori infection alone is sufficient to heal associated peptic ulcers and prevent their relapse and even recurrent bleeding in the absence of maintenance acid suppressive therapy. That being said, it's easier to tell you this than to actually do it, especially because we've got this mounting resistance to a lot of our antibiotic therapies that we use to eradicate H. pylori. So kind of just walking through this algorithm here, if you have a patient with ulcer-like symptoms, you want to first be really good internists like you all are and get a really good thorough history and physical so you can understand, what are the symptoms and better characterize those, as well as like where is the pain if they have any on physical exam, and also understand, make sure to get that physical or that social history about some of the risk factors that we talked about in the other slides. So if a patient has any alarm symptoms such as bleeding, anemia, or weight loss, then you want to proceed to an endoscopy to look at the ulcer to assess, do they have an ulcer? And if so, what can you do and better characterize that? So if you see an ulcer, you want to make sure to test for H. pylori, and obviously if that's positive, you want to treat and then check for eradication. If you treat and you find that their symptoms are completely resolved, then you don't need to really pursue any further treatment. However, if their symptoms persist 1 to 2 weeks after treatment, then you want to think about other things such as, did they take all the medications? Were they compliant with the antibiotics? Do they have antibiotic resistance? Are they on NSAIDs or on any other thing at the same time that could cause them to still be having persistent symptoms? Or is there any other etiology of their symptoms altogether? If you test for H. pylori and it comes back negative, then again, you want to think about other risk factors like NSAIDs. And if they're on NSAIDs, ideally you can discontinue them and treat them with a PPI. However, if they're on NSAIDs and you're not able to stop them, then think about whether you can decrease the dose or frequency, or if they can be switched to something like a COX-2 inhibitor. And also, if they need to be on PPI therapy to help treat the ulcer, as well as help for prevention in the long term if they're going to continue that medication. And then if you do endoscopy and you don't see an ulcer at all, then you want to consider if there's other etiologies present to explain their symptoms, like do they have really bad esophagitis? Do they have GERD? Do they have a malignancy or a mass there, or anything else that might be in the differential diagnosis? And then kind of on the left side of this flow chart, if you have a patient with ulcer-like symptoms and dyspepsia, but they don't have any alarm symptoms, again, the first thing to consider is one of the biggest risk factors, which is NSAIDs. So just like I mentioned, on the other branch, if they are on NSAIDs, think about stopping them. And if their symptoms resolve with discontinuation, then you're done. You can just watch them clinically. But if they have persistence of their symptoms, then you want to put them on a H2 blocker or a PPI and watch them. And if their symptoms still persist, then you want to consider if they need endoscopy. If they're not on NSAIDs, then think about H. pylori and then, test and treat. And if all of that stuff is coming back negative and you considered everything else in the differential and you can't come up with anything, then you want to proceed to endoscopy to get a visualization of what may be going on inside. And then, of course, I think we've all seen some of these complications when patients are admitted to us in the hospital. But the 4 major complications that can occur are bleeding, perforation, penetration, and obstruction. So now we're just going to review a case briefly. So we have a 67-year-old female with a past medical history of osteoarthritis, peptic ulcer disease, and hypertension who came into the ED because she was having epigastric pain, nausea, and fatigue. The pain had been present for over a week, and she's been progressively fatigued over the past three days, especially. She almost even passed out once at home when she was trying to stand up. Her medications include ibuprofen, lisinopril, and multivitamins. On exam, her vitals, she's a little bit tachycardic with a heart rate of 115. Her blood pressure is 100/64 when she's laying down. Her respiratory rate is 20, and she's sitting at 99% on room air. On exam, she's a pleasant female. She does have some mild abdominal pain to palpation in the epigastric region. No melena or blood on rectal exam that you notice, and you're not able to get orthostatic vitals because of lightheadedness upon standing. And then her labs are remarkable for a hemoglobin of 8.3 down from a baseline of 11, a creatinine of 1.2 from a baseline of 0.6, and a BUN of 38. So what would you do next, and what orders would you get? And y'all can feel free to chime in here.
Type and screen.
Yes. Anything else that y'all would want to get?
Some people in the chat said IV fluids, and I think this is Kelly, Paul, and Thara. IV fluids, stop NSAID and lisinopril.
Stop NSAID and lisinopril. Yes. Is there anything else that y'all would want to do as far as like medications? Like any meds you want to start?
They're saying PPIs in the chat.
Yes, that is absolutely what I was looking for. So anybody else have any other things they want to contribute before I move on?
Natalie's mentioning erythromycin. Someone else is saying serial CBCs and NPO.
Awesome. Those are all very correct. Erythromycin is definitely something that we consider more so before endoscopy, because it helps with motility and like helps to allow, usually if you give it 30 minutes to an hour before the procedure specifically, then it helps kind of move out the blood so that you get you optimize your chances of being able to visualize where the source may be. And then, so moving on, going along with what y'all mentioned with PPI. So, there's a lot of questions a lot of times that we have about whether or not you can use intermittent versus continuous PPI therapy for high-risk bleeding ulcers when you see these patients in the hospital. So there's been, a lot of different things, a lot of different studies that have come out. There was a systematic review and meta-analysis in JAMA that basically showed that intermittent PPI therapy is comparable to the current guideline recommended regimen of IV bolus plus a subsequent continuous infusion of the PPI in patients who were endoscopically treated for high-risk bleeding ulcers. So the thought is that the guidelines should be revised to recommend using intermittent PPI therapy. And it's important to note that pre-endoscopic IV PPI can be considered to decrease the proportion of patients that have higher risk stigmata at the time, or higher risk stigmata of bleeding at the time of endoscopy, and those who receive endoscopic therapy. But the PPI does not improve clinical outcomes that include bleeding, surgery, or death.
I just back to that slide.
Yeah.
So what we were trying to emphasize here is that, first of all, you can see that Lauren Lane, who's well known in the peptic ulcer world, basically put contradictory guidelines, right? She has an article in JAMA that says that we should change our regimen to intermittent PPI for economic reasons. But then she says on her management, which is an ACG practice guidelines, that she recommends an 80 milligram bolus followed by an infusion.
Mm-hmm.
So what I will say to this, and it's a debate for a different day, and I think it's beyond what the internist needs to know, but what the goal is, either by intermittent PPI or infusion, is to have a steady state of the PPI so that we're keeping our acid levels in the stomach low, that we're we're not changing the pH much. We want the pH to continuously be high to allow the ulcers to heal. Now, if you trust your MICU and you can think that they're giving the intermittent PPI at regular intervals appropriately every 12 hours, and they're doing a great job of that, well, that's a different story. But I think what a lot of studies are finding is that the ICU doesn't do a great job of giving PPIs when they're supposed to, and we end up having fluctuating levels of acid, and pH tends to drop, and that hurts ulcer healing. I think that when we look at European guidelines as well, and this is again beyond what an internist needs to know, but we find that most of our European colleagues are using PPI infusions because they're getting better ulcer healing and less rebleeding rates, though this has not been ever proven to be clinically significant. So I know every time we ask for you guys in the ICU to put on infusion, you say, you know, the pharmacy is going to give us a lot of pushback. There's not available. And we're okay with intermittent PPI, but if we could have our way, we would always use a PPI infusion because we get better steady state of acid blocking, higher pH, and we get better healing of our ulceration. And again, I agree with Natalie, it does help with platelet function, but that is a result of not the PPI, but that we increase the pH in the stomach. That helps with our platelet plug. All right, that's all I have to say.
Thanks, Dr. Brooke. And that kind of also is the point. I think you've covered a lot of the good points even in this slide, which so basically, like Dr. Brooke mentioned, there's some, controversy between the different studies as far as what we want to use. But I mean, I'm not going to harbor that point because I think he did a really good job of explaining it. So this shows the Forest classification for how we describe the endoscopic findings when we, scope a patient who has a bleeding ulcer. I don't put this slide up here for you to memorize necessarily. I thought this would just be something of interest maybe, so that whenever, you consult GI when there's a bleeding ulcer or a patient with an upper GI bleed, and we scope the patient, we treat them endoscopically, and we call you afterwards, hopefully, when we give the recommendations that we do, it'll make a little bit more sense as to why we're, giving those specific recommendations. So there's three main categories in the Forest classification. And one is if there's active bleeding, whether that be a spurting bleed or an oozing bleed. As you can see in the picture labeled A, these patients that have active bleeding have a 50% chance of rebleeding after endoscopy. So it's important for us to, do endoscopic therapy. And then class 2 is if there's stigmata bleeding. So if they have a visible vessel, an adherent clot, or a flat pigmented spot. And then class 3 is if they have a clean ulcer base. And with the flat pigmented spot and the clean ulcer base, those have lower risks of rebleeding. So they don't necessarily need to have endoscopic therapy. And then with regards to post-endoscopic care, so moving to the recommendations, for patients in the high-risk ulcer groups that I just reviewed, which is class 1A to 2B, those patients should get IV PPI for 72 hours post-endoscopy and a clear liquid diet. And after the 72 hours, they can be, if they're doing well, they can be transitioned to an oral PPI. And then those with low-risk ulcers, which is class 2C to 3, you can give them an oral PPI and a regular diet, and they may even be able to be discharged early if they are stable. And then the last bullet point with regards to anticoagulation, that in and of itself could be a whole talk, so I'm not going to go greatly into detail, but I think, when we think about whether or not a patient can resume anticoagulation, I think there's a lot of different things that need to be taken into consideration, like what is their indication, maybe a discussion between the primary team, the patient, the GI team potentially, and then even any other subspecialists, like for instance, cardiology, if their indication is AFib or something cardiac in nature. And I think it needs to be a risk-benefit balance and discussion, and things that we can use to help us in that are calculating the HAS-BLOOD score, the CHADS-VASc score. But at the end of the day, even with all the guidelines we have, I think the question of whether or not to consider continuing anticoagulation, and a patient needs to be tailored to that specific individual in their care. And then this is, so I'm going to hopefully be able to get this link to work here. But this just shows, again, I don't think you need to memorize anything, but I just wanted to show you some quick clips here so that, let me see. Are you guys able to see my screen? Like the video?
Peptic ulcer.
No, Deepika, you have to select the share again, and you have to select you should also click optimize for motion and video up in the top left when you click share.
Are you seeing it now?
Yeah.
Okay, great. So these are just some short clips that I thought I'd show briefly to because I think, at least when I was a resident, when I consulted GI for a bleeding patient for an upper GI bleed, they would tell me that they did, they injected epi or they put clips or whatever else treatment they did, but I don't know that I necessarily understood, exactly what was happening. So I think this just kind of provides a short little visual of some of the main types of treatments that we can do endoscopically. And then tell me if it's like not working or if you can't see it.
For actively bleeding ulcers, many experts advocate pre-injection in 4 quadrants to achieve temporary hemostasis and better visualization.
So this is epi treatment.
Injection therapy delivers temporary local tamponade and vasoconstriction.
And then the next thing is showing a little bit about the bipolar probe.
A visible vessel is seen within the duodenal ulceration. Thermal coagulation using a bipolar probe is used to achieve coactive coagulation. The probe is placed firmly on the vessel until cavitation or a footprint is obtained. For bipolar thermal coagulation, the energy output should be set at 20 to 25 watts, with the probe firmly applied on the vessel for several seconds.
And then the last one is just going to be a little quick visual of the of clip placement.
A visible vessel can be seen in this antral ulcer. Endoclip application provides the ability to approximate the ulcer or defect margins, as well as to achieve hemostasis. With these newer generation endoclips, en-face or tangential application is equally effective. To maximize the amount of target tissue captured inside the endoclip during clip closure, suction is recommended, with opened clip arms gently pressed over the target tissue immediately before clip deployment.
All right, let me see if I can get back to my slides. Are we back?
Yes.
Okay, awesome. So now we're going to talk briefly about some of the medical treatment options in peptic ulcer disease. So enteral nutrition is important because it acts as a buffer of the gastric acid. It also induces prostaglandin production and enhances regional mucosal perfusion, and then overall optimizes the mucosal energy and intramucosal pH. It may also provide protection against ischemic bleeding and increase the gastric pH to a greater extent than acid suppression. And then, we've talked about acid suppression, but you have the PPIs, which inactivate the parietal cell hydrogen potassium ATPase on the luminal surface. And then you have the H2 blockers, which block the H2 receptors on the parietal cell. Misoprostol is a prostaglandin E1 analog, and it works by increasing mucosal resistance and inhibiting acid secretion to some degree. And this can be used in prophylaxis for NSAID-induced mucosal injury. And then sucralfate is another thing that we sometimes use. And the way it works is by forming a barrier or coating over the ulcer crater, and it stimulates prostaglandin synthesis. It promotes the improvement of mucosal integrity and also overall enhances epithelial regeneration. And then we already talked a lot about H. pylori, so I'm not going to go into that too much. But one thing to just keep in mind is as we mentioned with the mounting resistance, if you are going to treat a patient, then just make sure to, check what resistances are in your area so that you pick the optimal antibiotic regimen for these patients. And then I think another question that comes up often is PPI versus H2 blocker. Is there one that's more effective? And, there are conflicting results. There was a study that showed that an H2 receptor antagonist was effective in preventing ulcers in average risk aspirin users. But then there was also another study that showed famotidine was inferior to pantoprazole for preventing upper GI bleeds or severe dyspepsia. And then, there's been a multi-center randomized control trial that found that in high-risk aspirin users, the rates of recurrent bleeding were similar between the patients receiving either a PPI or a standard dose H2 receptor antagonist. So currently, what we would recommend is that, what we know is that PPIs are effective for preventing ulcer bleeding with aspirin. But if a patient, is concerned about taking PPI long term, or they're concerned about side effects, or they're not able to take this medication for some reason, then famotidine is a reasonable alternative to consider in this population. And then, with NSAID-induced peptic ulcer disease, more than 85% of these ulcers typically heal within 6 to 8 weeks of PPI therapy after the NSAID or aspirin is discontinued. But it's important, as I mentioned earlier, that if you are going to need to continue the patient on this medication, and you think that they're going to be at risk, then you want to implement a preventive strategy by putting them on co-therapy with an anti-secretory agent. And again, PPI is the most popular choice in this case. And then also misoprostol is an option as well. It effectively prevents peptic ulcer complications with NSAID and things like that. And I think, are we okay on time, guys?
Yep.
Okay, cool. So just briefly, this slide just shows that, in patients that have refractory peptic ulcer disease, sometimes you need to consider surgical treatment. The good thing is that because we have much better medical management, we have preventive techniques, and then, we have better endoscopy and IR techniques. Overall, the rate of needing to send patients to surgery is declining. The most common reason that we do see for non-healing gastric ulceration is medical non-compliance. So if you have a patient, in the clinic or in the hospital, and you see that they're getting recurrent ulcers or they're not really responding to anything, then that's one thing to consider, is whether they're actually taking their meds or whether there's something else going on. And the major concern that we have regarding non-healing ulcers is that there's high risk of underlying malignancy. So the goal of treatment is also to prevent, cancer down the road. If patients undergo a truncal vagotomy, then there is a risk of delayed gastric emptying. And I don't think that you necessarily need to, know this much more than just to be aware of that. And in those patients, they may have to undergo a concurrent drainage procedure like an entrectomy, a pyloroplasty, or a gastroenterostomy for antral innervation. But people that undergo selective vagotomies, you don't need to worry about that as much. And then lastly, I'm just going to briefly touch on a little bit about prophylaxis and, some of the risk factors in the inpatient and outpatient settings that you should be aware of, or things to just consider in certain patient populations. So as far as in the hospital, when you see a patient that has any of these things going on, you should think about if they need prophylaxis to prevent an upper GI bleed. So some of these things to look out for are if they have been ventilated for over 48 hours, if they have coagulopathy, which is if they have a platelet count less than 50,000, an INR greater than 1.5, or a PTT that's 2 times the baseline. If they have undergone a recent TBI and their GCS is less than or equal to 10, or they're not able to follow simple commands, if they've undergone major trauma or have a spinal cord injury, or if they have burns that affect over 1/5 of their total body surface area. And then we had talked about NSAIDs and, putting them on preventive or using preventive PPI. But this kind of 2 things that you need to consider in these patients is their cardiovascular risk and their GI risk. So if they're low risk for both cardiovascular or GI complications, you can consider non-selective NSAIDs in these patients. If they're low cardiovascular risk but they're high GI risk, then you should do the non-selective NSAID but also add a PPI with it for prevention. Or you can do celecoxib plus a PPI. And then, as we mentioned earlier, definitely test and treat them for H. pylori along with, doing these other things. If they're high cardiovascular risk but low GI risk, then you can consider naproxen and you can add the PPI if the patient's taking aspirin. And if they're high risk for both categories, then you ideally would not put them on NSAIDs, but otherwise you can consider a naproxen plus a PPI or a low-dose celecoxib plus an aspirin plus a PPI as an alternative option. And I think that's it.
Deepika, go back to that slide. So I think this is like, if you don't take anything away from this lecture, this is the most important slide for the internist. Because I think we see patients in our clinic all the time, and it's a fault of us, is that we just have patients on PPI forever and ever and ever and ever and ever, and we never take them off. And we have patients that were on NSAIDs at one point in time and gotten a PPI appropriately by their primary care physician because they were trying to prevent any sort of bleeding. But I think it's really important and cost effective to get people off PPIs if they don't need it, especially if they have low GI risk and a low cardiovascular risk. We are safe placing them on a non-selective NSAIDs. I don't think you have to double up with a PPI, but if they've ever bled from an NSAID, they need a PPI for life. That's really important. And a lot of times we see patients that are not PPI forever. So somebody asked, when can we take them off PPI? I think that how we do it in our GI clinic, if somebody is well controlled on a PPI, you can start tapering it off. Remember, they're going to get some tachyphylaxis where they'll get worsening heartburn. It depends what your indication is. So if it's for GERD, then you need to treat the GERD. But if you're doing it for ulcer disease, once we've determined the ulcer is healed and we have a source, if it's an NSAID or if it's H. pylori, we can stop the PPI at that point in time. Unless the nidus is not removed, you can take the PPI off. So if the patient needs NSAIDs because they have osteoarthritis, then we would keep the PPI for life. If we're saying that aspirin was the cause of their GI bleed, then they should be on aspirin plus a PPI for life, or for as long as you determine that the patient needs aspirin based on their cardiovascular risk. So it's a tough question, and this is kind of what we use the slide. And there are some things I take a picture of. This is one that I would take a picture of so that I can always refer to it and look back so I can try to get my patients on and off the medications that they need. We see all the time that patients are on PPIs for unknown reasons, or they had an ulcer at one point in time and they don't need a PPI anymore. They come in the hospital on our GI ward service, and then we see them in clinics. This is a really, really important slide. I can't emphasize this enough.
Can you guys talk about using PPI prophylaxis with steroids as well? I think we always associate NSAIDs with it, but if we're sending somebody home on a burst of steroids or a long taper, what patient population do you start a PPI in, or do you need to?
Deepika, do you want me to take this?
Yeah, I mean, that's fine.
So no patient population. Steroids are basically a compounder to something else. I think you did have a slide on that, but
yeah.
Steroids are not an independent risk factor of themselves for ulcer formation, but they they increase the probability of an ulcer forming from other things. So even though a patient's on a steroid, they don't necessarily need to be prophylactic on a PPI. If they're on steroids plus an NSAID, which we see in people with rheumatoid arthritis or osteoarthritis or something like that, then they do need to be on a PPI. But just steroids by themselves for a taper, I wouldn't necessarily prophylax. I don't know if anybody else has different experience.
And I think another population that at least I remember seeing a lot of this happen in is patients with COPD that come into the Hawksworth primary care clinic, or they have really bad asthma, or for some reason they need to be on an extended taper of their steroids for that. But they also have coronary artery disease and they've had stents and, they're on dual antiplatelet with an aspirin or something like that, they're high bleeding risk, just like Dr. Brook mentioned. Those are the people I think that then you would consider if they need prophylaxis.
But once you get off the steroids, get off the PPI. Don't leave them on the PPI forever.